Dr. Scott Warden, the TOS guy. Today we have a really special guest. Dr. Vernon Williams is an expert and experienced TOS specialist who works with tons of athletes at the Cedars-Sinai Sports Neurology and Pain Medicine Clinic. I hope I got that right. Welcome, Vernon. I'm looking forward to your talk.
Well, it's my pleasure to be here, and you got it really close to right. It's the Center for Sports Neurology and Pain Medicine. So that's a mouthful, I know.
Thank you. So today, tell us what you're going to talk about, and we'll let you go.
Well, why don't we go ahead and jump right in, man? I've been looking forward to this for a while. I'm going to just get my screen set up here, and hopefully everybody's going to get that. And so this is our title, Thoracic Outlet Syndrome in Athletes. And even though I'm going to be talking about this topic from the standpoint and perspective of athletes, these things are really generalizable. They can be applied to what we call our non-athletic patient population or civilian population. I see patients all the time who are not professional or collegiate athletes. They are weekend warriors. They are people who are working every day like everyone else. They've been in motor vehicle accidents or slip and falls or whatever, but they may not be elite athletes. So topic is thoracic outlet syndrome in athletes. But just like a lot of other things, we learn a lot of lessons when we treat these athletes that can be applied to, the general population. So as mentioned earlier, I direct the Center for Sports Neurology and Pain Medicine. We are part of the Curlin Job Orthopedic Clinic affiliated with Cedars-Sinai Hospital. And I don't have anything to disclose. Often when we're talking to other physicians and doing CMEs, we have to specifically state that. So here's our introduction, our topics of discussion. We'll talk a little bit about sports neurology and pain. We'll talk a little bit about the history of this particular topic within sports neurology, and then we'll get to the presentation. I've got some cases that I think are interesting. We'll talk about how these patients present to our practice. We'll talk about how we go about evaluating and diagnosing thoracic outlet syndrome, review a little bit about management, and then hopefully we'll have a lively discussion. As I said, I direct the Center for Sports Neurology and Pain Medicine. And so this is a comprehensive center within an orthopedic medicine practice, within a multidisciplinary practice. I see lots and lots of patients with neurologic injuries that have been suffered while participating in sports. So we're talking about obviously things like concussions, but also things like injuries to the spine or spinal cord, to the brachial plexus, peripheral nerves, those kinds of things. In addition to that, the center focuses on other things related to sports neurology that may have to do with individuals who got some kind of neurologic diagnosis and whether it's safe for them to participate in sports. That may have to do with applying some of the lessons we learn about optimizing performance from a neurologic perspective, meaning improving focus and concentration and speed of mental processing, balance, vision, all of those things, but applying those to individuals who have a neurologic diagnosis like Alzheimer's or Parkinson's or what have you. And it has to do with just optimizing neurologic function across the lifespan, making sure that people are optimizing. They're doing all the things they like to do, want to do, need to do at the best of their abilities across the entire lifespan. And when you engage the nervous system, the brain, the spinal cord, and the neurological systems, you can assist with that. So that's a little bit about my practice. And I end up seeing a lot of individuals who have symptoms of thoracic outlet syndrome associated with sports and athletic injuries. So I want to move on and talk a little bit about kind of the history of TOS in sports neurology. Now, if we go way back to one of the first textbooks ever published, this goes back to the late 90s. This textbook was published by Barry Jordan, who's a colleague and friend, Peter Saris, Russell Warren, back in 98, an entire textbook on sports neurology, one of the first. And in that textbook, there is some discussion about peripheral nerve injury in sport. But the discussion is really interesting. At that time, there was a lot of discussion about the mechanisms. How are peripheral nerves injured? Is it direct trauma or microtrauma? And then classifications of these injuries, neuropraxia versus axonotmesis or neurotmesis. how you can diagnose them with electrodiagnostic testing. And then there's a rundown of different sports where peripheral nerves may be injured. Interestingly, they talk about throwing injuries and running injuries. One of my, the founders of my clinic, the Curlin Job Orthopedic Clinic, Dr. Job, and a lot of the biomechanics work done on pitchers and the injuries that may be suffered by pitchers, the biomechanics associated with that were found in that textbook. But they did also discuss peripheral nerve injuries involving the brachial plexus, what we see in thoracic outlet syndrome. Interestingly, the only sport discussed was football. And so even though we know, and we'll get to this over the next few slides, that there are a lot of ways you can suffer from thoracic outlet syndrome or injure the brachial plexus in sports, they only covered this as a small section in that entire textbook related to football. And they talked about the incidence and how frequently we see those kinds of injuries. By 1978, there was 2.2 cases per 100 players. They talked about the fact that in some studies, people who had narrowing of the spinal canal or spinal stenosis were more likely to have these brachial plexus injuries, or stingers as they were called. They talked about the possibility that the brachial plexus could be compressed against the shoulder pad in individuals who are playing football. And then a little bit of discussion about mechanisms and what have you, but all limited to football. Fast forward, we're still talking about the history of TOS and brachial plexus in sports neurology. Back in 2009, this textbook came out. And there was a discussion about peripheral nerve injuries. Corey Toth was the editor. This textbook really had a lot of tables with descriptions of injuries that can happen with certain kinds of sports. But there was a brief discussion of brachial plexus injuries, now not only limited to football, but they also talked about these kinds of injuries in individuals who were weightlifting and bodybuilding. And they talked about how muscles can be hypertrophied or enlarged. And that, combined with some of the degenerative changes associated with the shoulder, could decrease the size of the thoracic inlet, leading to compression of the brachial plexus. Put a pin in that. We're going to come back to that in one of our cases. And then a little bit later on, we see that there was this continuum publication back in 2014 that the American Academy of Neurology published. I published an article in this continuum. Brian Hainline, who was the current president of the American Academy of Neurology Sports Neurology section, did a chapter on peripheral nerve injuries in sports. And he talked about a variety of things, including brachial plexus injuries from compression or from stretching. He talked about the whole concept of periodization. In other words, if you do too much too quickly, and how you can overuse certain muscles and extremities, and that could contribute to these kinds of injuries. I also talked about brachial plexus injuries and thoracic outlet syndrome, not just in football and weightlifting, but a number of different sports, softball, overhead throwing, and how we can diagnose them now in 2014. In addition to just x-rays and CAT scans, we could do diagnostic ultrasound and identify changes that are consistent with the diagnosis. So that's just a little bit of history about how things progressed from 98 up to 2014. We started to see a little bit more recognition, a little bit of an evolution in our understanding of thoracic outlet syndrome and brachial plexus injuries in sports. Now, I want to talk for the next few minutes about the following things. How do we encounter these injuries? How do we evaluate them? How do we frame this issue of thoracic outlet syndrome in athletes? Does our experience in athletes and the context differ in any way from the civilian population? A lot of overlap. There may be some unique aspects of evaluating and treating athletes. What are the dominant clinical presentations? How do we typically see these patients come in? And what lessons can be extrapolated? How can we evolve and use the things that we learn in this kind of natural laboratory of treating sports and athletes and extrapolate that and apply it to the general population so that everybody can perform the way they like to and want to, minimize their pain, maximize their function, that kind of thing. So one of the ways to think about thoracic outlet syndrome and brachial plexus injuries is to categorize them based on how they present. And we can do that and kind of discreetly describe them with respect to the onset. Is there a sudden or a gradual insidious onset? What part of the brachial plexus is affected? The upper trunk versus the lower trunk. And you can see the chart there. And it turns out that when we talk about stingers, that's something we often see in football, in hockey, in wrestling. When there's a sudden onset of injury, it's more likely for the upper trunk to be affected. It's normally a nerve issue. And those tend to be self-limited. People will come in and say, yeah, this happened and I had symptoms for 10 minutes or 15 minutes or 12 minutes, and then it kind of gradually went away. That's what happens most of the time, not always, but most of the time. As compared to what we might call thoracic outlet syndrome rather than a stinger, meaning there's a more gradual or insidious onset. More often, the lower trunk of the brachial plexus is affected, and these individuals will often have neurovascular symptoms. Some symptoms attributable to nerves, other symptoms attributable to blood vessels. It can be arteries or veins. They may have more swelling or temperature differences or discoloration or those kind of vascular features. And we tend to see these kinds of injuries in other kinds of sports. Overhead sports, like baseball players who are throwing and stressing the extremity that way. Sometimes with fast pitch underhand baseball. Swimmers. These are individuals where people may have a more gradual onset, and these symptoms tend not to just go away on their own. They more likely require some kind of intervention. Now, I want to talk about a few different sports. We're going to talk about one Major League Baseball player. We're going to talk about two collegiate football players. We're going to talk about three NBA players who I've seen over the last few years that I think are good examples of TOS and brachial plexus injuries in athletes. So this Major League Baseball player happens to have been an MVP, a league MVP. 24-year-old, he comes in to see me. He had right neck and arm pain that had been present since a shoulder injury he had. He had tripped and fallen on the field, arms stretched out in this prone position, and injured his shoulder. Now, since then, he had been having pain and soreness in the back of his shoulder and the anterior part of his neck. And he would get episodes of pain radiating into his arm, down to the elbow, down to the wrist, into the fifth digit. He had had lots of tests done, MRI of the neck, MRI of the brachial plexus, MRI of the shoulder, MRI of the wrist, MRI of the elbow, EMG nerve conduction, all of them normal, yet he was continuing to have these symptoms. He had done lots of physical therapy with their training staff, working on his posture and his shoulder and soft tissue work, still having symptoms. But his physical examination to me was critical because one of the most important things is that he had severe tenderness in this supraclavicular fossa, this area just above the collarbone or clavicle. And in addition, he had a lot of spasm of the scalene muscles, these two muscles that attach to the first rib and are often involved in this process of thoracic outlet syndrome. Moreover, he had what's called a positive ruse sign, which is a sign that we'll often look for on physical examination. Now, I ended up, even in the absence of him having any objective abnormality on MRI of the brachial plexus, as a diagnostic test, I did an injection of those scalene muscles. I wanted to see what would happen if we relaxed those scalene muscles, opened up that scalene triangle, and had some effect on his symptoms. If we did, then that to me was very consistent with thoracic outlet syndrome. And he did. Lo and behold, he had a dramatic improvement after the scalene block, local anesthetic and cortisone. He came back later on. We did a scalene Botox injection at the All-Star break, and he did great. He had an amazing season, so much so that at the next season, before the season started, he came back and said, hey, I had a little bit of return of those symptoms. I need to get that injection again. We did it, played the entire season, and then the following season, he did the same thing. So this was an individual, normal imaging, normal EMG nerve conduction study, yet had all the clinical features of thoracic outlet syndrome. We treated him as such, He did great, returned to Major League Baseball on an MVP level. Let's talk about a couple of collegiate football players, NCAA players that I've seen. This first one, the athletic trainer sent a player in to see me. He was a linebacker, college linebacker, and had a history of multiple stingers. In the typical episode, he would have these severe burning pain in the neck, in the trapezius, in the arm, no weakness, just the pain. He had an MRI of the neck already that showed enlargement of the facet joints, these paired joints in the cervical spine, and a little bit of foraminal narrowing, meaning where the nerves exit the spinal canal a little narrow. He had multiple episodes in that Saturday's game. He comes in, physical examination. He does have, again, tenderness in the supraclavicular fossa. He had great painless range of motion of the neck, which would be unusual if his pain were coming from those facet joints. His motor exam was normal. His sensory exam was normal. So he had a little bit of a mixed presentation, unclear whether his symptoms were from those facets, like facet syndrome, maybe from nerve roots, because he did have narrowing where the nerves are exiting, or was this a plexus presentation? I ordered an MRI of his brachial plexus, and sure enough, he had non-specific diffuse edema, swelling, fluid, prominent in the divisions and proximal cords, and prominent supraclavicular veins that may have been having an effect on parts of the brachial plexus. But this was suggestive of some traction injury or plexitis, and we treated him as such. He ended up being given an oral steroid taper medication to suppress and reduce inflammation. I did some intramuscular trigger points, but held off on the scalene block. But he actually ended up doing very well with that. So now we got an individual who had an MRI showing some abnormalities of the neural structures, maybe some changes in the venous or vascular structures, but we did not do scalene injections in him. We had him do aggressive physical therapy, strengthening of the cervical spine, put him in a collar when he played, and he did very well. The second collegiate player, 21-year-old with a 4-year history of stingers. Back in high school, he would get 1 or 2 stingers a season. By college, he was getting 8 to 10 stingers per season. It would typically have symptoms into the C5 distribution, which is kind of in the shoulder, that the soldier's patch area of the shoulder. And he said that this would normally be triggered by a blow to his head or neck in extension. Symptoms would last 1 or 2 minutes and resolve. The problem and the question and the difficulty was that these were accelerating in frequency. His physical examination was most significant for what I would describe as poor posture. He had shoulder girdle laxity, some drooping of the shoulder girdles, anterior rotation or internal rotation of the shoulder girdles. Otherwise, his physical exam was pretty unremarkable. This young man had an MRI of the brachial plexus that showed scalene muscle hypertrophy, enlargement of those scalene muscles, and that enlargement resulted in narrowing of the interscalene compartment. This is similar to what was described in that second book we talked about, that we can sometimes see in weightlifters and bodybuilders, where their body habitus enlargement of those muscles will effectively narrow the interscalene compartment. So that's what happened with this guy. This person, I did elect to do a scalene block, see what would happen if we relaxed the scalene muscles, followed that with scalene Botox injections, aggressive PT to try to keep those scalene muscles stretched, and did some scapular strengthening and postural work, strengthening the levator scapulae and the trapezius muscles that help to elevate the shoulder, the levator scapulae helping to pull that shoulder blade back against the chest wall. Also put him in a scapular stabilization brace and posture shirt to help support him. And he did very well, returned to football, continued to play, and was a success. So now we've talked about a baseball player. We've talked about a couple of football players. Now we're going to talk about 3 NBA players. These are National Basketball Association players that I've seen that are good examples of thoracic outlet syndrome. The first was a Laker. At Curl and Joe, we've taken care of the Los Angeles Lakers and took care of them for over 30 years. At the end of one of their seasons, it was actually a championship run. You know, they had their exit histories and exit physicals. And this particular player, you know, was sent to me because he had had a number of stingers And he said that he would run into picks. You know, in basketball, they're playing and, you know, setting picks for a teammate. He would run into a pick or run into a player and get these electric shooting, radiating symptoms into the upper extremity. It could be the left or the right side. The symptoms would last for a few minutes. He could kind of play through it, and then it would go away. He also had a bit of neck pain and stiffness. His exam, unremarkable, except for a slight reduction in sensation to pinprick in the lower, the left upper extremity, rather. He ended up having imaging of the cervical spine and imaging of the plexus. The cervical spine imaging was fairly unremarkable, but MRI of the plexus showed some edema within the upper, middle, and lower trunks, consistent with increased endoneural fluid. He also had a bit of a variant course of the lower trunk of the brachial plexus, and he had some changes in the AC joint. This joint was widened and had some findings consistent with previous traumatic injury and mild supraclavicular edema. He ended up being treated conservatively. It was end of the season. He did not have to undergo any injections. We just made sure that he had a lot of good physical therapy and athletic training work on posture, working on the scalenes, working on the pec minor, and we ended up being able to treat him conservatively. A second player, different team, actually didn't even play for the Lakers, but I got a call. I had seen him for something, a few years before. He, 36-year-old, this is during a playoff run, middle of the playoffs. He had sudden onset, severe right shoulder pain after a fall on the court. He said he went up for a rebound and kind of heard a crack. He didn't know if it was his neck or shoulder or what, but severe pain, goes down on the ground. And as soon as he hit the ground, he felt that he had a completely dead arm. Couldn't use his arm at all. Sudden burning pain into the shoulder, burning pain radiating into the arm, the wrist, and the hand. Now, he had a remote history of dislocation of the same shoulder. He thought he had dislocated his shoulder again. That's not what happened. After his previous shoulder dislocation, he had some scapular dyskinesis or abnormality in scapular motion, but it had improved. He also, upon questioning, he had a long-standing history of that arm kind of falling asleep at night. He'd wake up in the middle of the night, the arm would fall asleep. He had to shake it and move it to kind of get the circulation back. So those were important parts of his history. At the time I saw him, he had come into Los Angeles because they had a game in Los Angeles. No pain at that time, but still had a little bit of weakness in his arm. And he said his arm just didn't feel right. Physical examination, he had difficulty proximally, pretty good strength distally. But interestingly, he had severe anxiety. He was scared to death. Is my arm ever going to get better? We're talking about a day or so after the initial injury, he still had weakness. So he ended up getting imaging of the brachial plexus. The brachial plexus MRI was normal. There was no significant evidence of neurovascular compression, no signal alteration, anything like that. On his cervical spine MRI, he did have straightening of the cervical lordosis. And then he also had an annular fissure in the C5-6 disc. And other than that, pretty unremarkable. This guy, I ended up treating conservatively. He ended up getting an oral steroid, no injections. The steroid helped, we believe, further reduce inflammatory changes or inflammation. And he got gradual return of his strength over the course of the next day or so. And a lot of reassurance to let him know that, his physical examination was improving. His imaging didn't have any red flags. He ended up, returning to play and played the rest of the playoffs and had a great playoff run. I still believe that his symptoms were related to stinger or brachial plexus, not related to the cervical spine, but he just had a prolonged recovery with his weakness. And then the last patient case that I want to talk about is one of my favorites. This young man, let me give you the other things that we did with the second case: steroid taper, the posture shirt, physical therapy, and a lot of reassurance. So the last case, so second-year NBA player, He had a history of scapular dyskinesis, again, abnormal motion in his shoulder girdle that had improved. He was referred to a hand surgeon, one of my partners who is a hand and wrist specialist, because he was having wrist symptoms and hand symptoms in his shooting arm. He was in a shooting slump. He was playing less. In fact, was on injured reserve when I saw him. And one of his questions and complaints was that the ball just didn't feel right in his hand. He had difficulty feeling the ball in his hand, and he had a lot of reduction in wrist extension. He didn't feel like he could cock his wrist in his shot, or his fingers didn't extend normally with his shot. He had a little bit of motor deficit, some subtle weakness, and he did have some sensory changes in his right upper extremity. He also admitted to waking up in the night with his arm having fallen asleep, numbness and tingling. And he felt like he fatigued very easily. In fact, he would try to just put up as many shots as he could, just trying to shoot himself out of this slump. And the more he tried, the more he would get fatigued, and all of his symptoms would worse. Now, on examination, he had, again, spasm in those scalene muscles, pretty significant shoulder girdle asymmetry with laxity on that right side. He had this subtle kind of fullness in the upper extremity on the right. And from a physical examination, those were the most critical factors. Importantly, emotionally, this young man was very withdrawn, depressed because of this injury that had just kept him out of the lineup and wouldn't go away. Difficulty with just interaction and that kind of thing. So he had a lot going on. We did end up ordering some tests on him. He did have an MRI of the brachial plexus that showed a narrowed interscalene compartment, but normal signal intensities of those neural structures. He had an electrodiagnostic test that showed reduced medial antebrachial cutaneous sensory amplitude, which was suggestive of some changes or abnormalities in the brachial plexus. Now, I ended up doing a diagnostic scaling block on this young man. He called back with his agent the next day saying he hadn't felt that good in over a year. And so we said, all right, we're on the right track. We brought him back. We did scaling Botox, and he ended up doing very well initially, but he went back to training with his shooting coach and seeing a chiropractor. And again, trying to just shoot himself out of this slump, his symptoms came back. He ended up getting traded from that team to another team. The second team said, hey, listen, you guys have him for as long as you need him, but we want him to come back ready to play. So we were able to do a really deep dive and figure out what was going on from the standpoint of his current symptoms, but also what likely caused those symptoms. And as it turned out, he had a knee injury way back in college. He rehabbed from the knee injury, but never really returned to using his entire kinetic chain. In other words, he wasn't jumping and using his legs with his shot. He changed his shot and was now using his arms more in the absence of his legs. He wasn't using the kinetic chain. He wasn't generating power from his lower extremities. And with a good physical therapist, we were able to identify that that's what was going on. And we just stripped everything down to the basics, foundational approach to rehab. We also added some neuromodulation, which was transcranial magnetic stimulation, working on things from a sports neurology standpoint, had very gradual and limited and monitored progression of his activity. We wouldn't even let him touch a basketball for a while. Gradually get back to handling a ball, gradually get back to shooting. And he has done extremely well. He ended up getting a contract extension, eventually returning to the starting lineup. And most importantly is the bottom statement there is that he got his confidence back because someone had finally identified what was going on and why. And it wasn't in his head. It wasn't something he was imagining. He hadn't kind of lost his mojo. He realized, hey, this is the sequence of events. This was an individual, in my opinion, developed thoracic outlet syndrome after a knee injury. Because what happened before what happened is that he had the knee injury. He rehabbed, but never the way he should have, changed his shot, the changed mechanics ended up resulting in the TOS symptoms. And again, he was sent to a hand specialist because the thought was this is a wrist or upper extremity issue before we were able to identify the thoracic outlet. So those were some examples of some of the things that we see and some of the ways these patients and players have presented. Let's talk about TOS. And these are some basic foundational principles. We know about the anatomy of the cervical spine, the anatomy of the brachial plexus, and put those things together. We know that those nerve roots from C5, C6, C7, C8, and T1 exit the cervical spine and are at risk in 2 or 3 different locations. One of those locations is between the scalene muscles. Another location is between the first rib and the clavicle, or so-called costoclavicular space. And a third location is out at the pectoralis minor attachment, or behind that attachment. So when we see an individual with their shirt on or with their shirt off, we see the surface, but we've got to start thinking about what's going on deeper. And that may be the bony anatomy, meaning the clavicle, meaning the first rib, and the spacing and what's going on there. But we also have to keep in mind what's going on from the standpoint of soft tissues, meaning muscles and ligaments and nerves and arteries and veins. It's a complicated area, and people can present with a lot of different kinds of symptoms, but we want to focus our physical examination on these areas so that we can take someone who has these kinds of symptoms, identify what may be causing it, and kind of test and evaluate and intervene and intervene with treatments that are helpful. So if we talk about the symptoms in light of that anatomy, we know that effacement or compression of nerves or blood vessels may be positional. So often people will say their symptoms are worse in certain positions compared to the others. They may be transient or wax and wane. They may say, yeah, at time I get a lot of tingling and numbness. I wake up in the middle of the night and my arm is falling asleep. Or if I have to use my arms at or above shoulder level, I fatigue easily. Or if I'm putting up shots, I fatigue easily. And the symptoms may involve the nerves with numbness or pain or weakness. It may involve the blood vessels with changes in temperature or discoloration or swelling or edema, or both, some combination of those. And we have to keep in mind that it may be arterial or venous. And in my opinion, I think venous congestion and venous compression is more commonly seen than arterial. But again, there may be scenarios where people have an aneurysm from some arterial injury that occurs and causes thoracic outlet syndrome. I think that it's important to understand that there's certain people who may be predisposed. And the predisposition may have to do with their anatomy or body habitus, the cervical spine, if it's long or straight. Sometimes we'll see an MRI, and if you notice, that was in one of the cases where there's less of the curvature, a straightening of the cervical lordosis. We talked about the cervical spine issues way back in 1998, the first book with Sports Neurology. They talked about the narrowing of the canal as a ratio to the size of the vertebral body, scoliosis or cervical ribs, of course, obesity. All of those anatomy and body habitus issues may predispose someone. Vascular or nerve or bony anomalies may predispose. And then there are developed or environmental factors, their posture, trauma. It may be a fall. It may be a shoulder injury. And of course, they may have had a tumor or some post-surgical change, but those things can predispose people. Classic symptoms, the things that we are taught, are individuals who have this kind of combination of neck and shoulder and extremity symptoms, especially if they're neuropathic, meaning they're associated with numbness or tingling or weakness or some vascular symptoms. Those, we should immediately think about the possibility of thoracic outlet syndrome or some brachial plexus etiology. But there, I believe, are some new classic symptoms. These things should be added to the classic symptoms. If people have unilateral or asymmetric extremity swelling, if they have temperature changes on one side compared to the other, if they have severe tenderness in the supraclavicular region, all of those things I think should be looked for, and if they're present, should raise the suspicion. And there's some other things that may be overlooked and often go overlooked for an extended period of time. So people who have hand or wrist or elbow symptoms that are otherwise unexplained, people who have muscle spasm, chronic tendonitis. Sometimes we'll see people who say, oh, I've got, tennis elbow and golfer's elbow and, you know, all these different kind of tendon symptoms, or they've been diagnosed with those, maybe those are manifestations of thoracic outlet syndrome. I've seen it. So the differential diagnosis is, yeah, it could be a cervical spine or a shoulder or a peripheral nerve injury. But when we think about the brachial plexus and thoracic outlet, often that is kind of a unifying hypothesis. So it's fortunate that people will often have an inaccurate or incomplete diagnosis. In other words, they're told that they've got AC joint arthritis, or they've got facet arthropathy, or something going on in their neck, yet they haven't gotten better with treatment. And that can be physical therapy, it can be surgery. And often they come back and they're worse than they were before the surgery. Now, in addition to the physical symptoms, they also have depression or anxiety because their symptoms have been so prolonged. And this picture, this constellation of signs and symptoms should be a clue. Thoracic outlet syndrome can be a unifying hypothesis. In other words, it's something that would explain everything. And my shoulder colleagues and orthopedic specialists will say, hey, listen, I see your shoulder issue, but that doesn't explain to me why you got symptoms radiating down your arm. Or our spine surgeons may say, hey, yeah, you've got some cervical spine issues, but that doesn't explain to me why you got swelling in your upper extremity. So, you know, when we recognize that some of these pieces don't fit, TOS can be a unifying hypothesis. It's a complex anatomy, but it's testable, and there are effective treatments. So we can get someone going from this kind of picture to this kind of picture. They can get that arm elevated. They can use the extremity without a problem. So this knowledge can help athletes in terms of insight as to what's causing their symptoms, help with early referral to the appropriate specialist, avoid misdiagnosis, and then you get faster and more cost-effective and accurate results. How do we approach this? There are electrodiagnostic tests that might be helpful, EMG nerve conductions, even SSEP studies. There are vascular studies that might be helpful. There's diagnostic imaging, and in my opinion, and for my money, the best is probably going to be an MRI of the brachial plexus. But you may glean information from diagnostic ultrasound or x-rays of the cervical spine, identifying a cervical rib or other vascular abnormalities. And then I believe part of the diagnostic approach is identifying that person's response to scalene injections if there is a scalene component, or pectoralis minor injections if there's a pectoralis minor component. The take-home message is that there is no one gold standard diagnostic test. We suspect this diagnosis based on the clinical presentation, based on the physical examination, and then we have this supporting evidence that may or may not be present from the standpoint of these tests that we've talked about. And if we suspect it or have made that diagnosis, there are a number of different treatment options. Everybody doesn't need surgery for TOS. In fact, most people don't. There are non-surgical treatments. There are things like injections, which we've mentioned. There's physical therapy, which we've mentioned. There's retraining the muscles to work on proprioception and positioning. There's biofeedback to relax certain muscles and quiet the autonomic nervous system. There are medications that may be helpful in terms of reducing neuropathic features of pain and reducing pain. And so what I like to say is, hey, listen, most people are going to respond to conservative treatment, physical therapy, medications, working on their posture and shoulder girdle mechanics, muscular retraining. Some people, that won't be sufficient, and they may need or benefit from certain kinds of injections. We can do trigger point injections into different muscles, and those can be done with local anesthetic alone. Sometimes, and in certain situations, we'll add steroid to those intramuscular injections. And then there's Botox, which can relax muscles for extended periods of time. And the way I like to frame this is, hey, listen, Botox should be something that works for months at a time. And it's not that Botox by itself is going to cure your TOS, but Botox will give you a 3 or 4 or 5 month runway that you can optimize your mechanics with physical therapy and biofeedback and muscular retraining and what have you. And then, yes, there are some individuals who have such a significant structural abnormality that they need a surgical intervention. If they've got a cervical rib, if they've got an aneurysm in one of the arterial vessels, And sometimes if people have extreme, severe, incapacitating symptoms, despite the first two steps, then surgery may be indicated. In my opinion, that's fairly uncommon. So if we talk about a kind of a contemporary discussion for thoracic outlet syndrome in 2022 and beyond, let's talk about this. How do we encounter these individuals? How do we evaluate and assess their symptoms? How do we frame the diagnosis to them? How do we manage TOS in athletes versus the civilian population? Does our experience and context differ in any way from the civilian population? What lessons can we learn and extrapolate to the civilian population, improve function, quality of life, and performance in these non-athletes, just like we do in our professional players? So that's all I have in terms of discussion. And I am open to suggestions and questions and comments. This is kind of a little synopsis of what we talked about. If we start at the 1 o'clock position, we talked a little bit about the symptoms of thoracic outlet syndrome being pain, and it's usually neuropathic, radiating, shooting, numbness and tingling, and sometimes weakness. If we go to 3 o'clock, where it says mechanisms, we've talked about how people can have stinger-like mechanisms as athletes, traction injuries with certain kinds of sports, compressive injuries, or they can have more insidious, gradual onset of symptoms from repetitive trauma or sustained position or altered mechanics like hypertrophy of those scalene muscles or what have you. And then we talked a little bit about the anatomy in terms of the cervical spine and the scalene triangle and the costoclavicular space, the pectoralis minor space. Those are the areas where this neurovascular bundle is at most risk. We talked about the physical examination, the diagnostic tests, again, focusing primarily on imaging studies like MRI of the brachial plexus, sometimes ultrasound. And by the way, as you saw in some of the cases, sometimes the imaging study is normal, yet that person has thoracic outlet syndrome. So these are things that can be considered and may be helpful as supporting evidence, but they don't rule out the diagnosis, in my opinion. And then we talked about treatment options, non-invasive treatments like medications and acupuncture and physical therapy, and then some minimally invasive treatments like injections, and then more aggressive treatments like scalenectomy, which is one surgical approach, first rib removal, which is a different surgical approach. And in athletes, we talk about return to play as well. When can this individual return to play? And what kind of things we think about in that situation? We think about relative contraindications to return to play, like if they're having repeated and recurrent episodes, or if they're having symptoms lasting for more than a day. And then we talk about absolute contraindications, meaning they have ongoing and persistent neck pain or loss of motion or neurologic deficit. And those are the things that we tend to think about with respect to this condition. There's several references here. I'm happy to provide that at a different time if people are interested. And yeah, that's all I have prepared, and happy to kind of talk about any of those things or answer questions at this time.
Vernon, that was great. If I could use one word, it was a very holistic approach. It's really a pleasure to see that as we all focus on these tiny bits of anatomy. You went through everything from posture to the knee injury to the scapular dyskinetics and how it all can result in a chain of problems. So that's really good to hear, as well as the emotional overlay of depression in some of these people.
Absolutely. It's all part of it, Scott. You're absolutely right. And if we try to focus on one thing in the absence of those other things, it limits our success, right? So I think we have to pay attention to all of that. Yeah.
It's rare to have somebody like you who really focuses on so many things. In a big picture, you can step out to 30,000 feet and then come back into the tiny details. And that's absolutely true. I think the successes we've seen with patients in Northern California tend to arise from multiple specialists pitching in together. It's kind of a job you're doing in your own brain by yourself.
Well, I think you make a great point. There's so many different specialists who encounter these patients, right? So they may be orthopedists, they may be neurosurgeons, they may be pain specialists, they may be neurologists, they may be vascular surgeons. I mean, so it really does take a village, because at the end of the day, if you suspect or initiate treatment, you need physical therapists. You need, in some cases, injectionists, in some cases, surgeons, and so psychologists. I think it's a good idea to have a multidisciplinary approach, because these tend to be more chronic conditions, and those individual patients, I think, really benefit from that multidisciplinary approach, an interdisciplinary approach.
I wanted to zoom in on a few things that you said as I took notes from your talk. Let me start with the first one. A point I wanted to make is that your beautiful layout of these different athletes and picking apart what ended up being the problem and the solution shows how much variety there is in TOS. It's not just one big disease, is it?
Man, you know what? I almost had a completely different approach to this talk, and I was going to talk exactly about that point. And the point being that these patients can present with lots of different symptoms, all from TOS. And I don't know about you and your practice, I'm sure you can comment on this, but I think you start to see these individuals, and some of them have symptoms that are related to facial symptoms or headache, others upper back and shoulder, others radiating into the arm or wrist. So the location can be very different from person to person, and the kinds of symptoms. Some of them, it's more, neurogenic with weakness and pain and numbness. Others, it's more vascular with swelling and discoloration and temperature difference. Others, it's a combination. So it's a complicated diagnosis in a way, until you start to recognize and appreciate it. And then you start to see, well, wow, this can be a part of lots of symptoms that patients come in with. And so I think you're absolutely right. It can present in a number of different ways. That's an excellent point. Excellent.
You have a great way of putting it. I think for some clinicians, when they see a TOS patient, maybe the clue to them is that this thing does not fit. This clinical picture is not a radiculopathy. It's not a single nerve. It's not a single location. And maybe that should clue them into thinking, step back a bit and see the whole picture, which you aptly did.
Yeah. And you know what else, Scott? I think another thing that maybe is a clue is when individuals fail to respond to things that should work, right?
Great point.
So,
Great point.
they've had a lot of physical therapy, it's just not getting better, or they've had surgery for carpal tunnel and yet they're still having symptoms, right. Or surgery for, tennis elbow, yet they're still having symptoms. So that's another scenario, in my opinion, where you see the person and you say, wait a minute, how many surgeries have you had on your arm? Or how, right. And then one of the things that, unfortunately, I think about in those cases is maybe we've been focused, or people have been focused on the wrong anatomy. Yeah.
So Vernon, you did bring up multiple crush syndrome. You talked about overlooked diagnoses, pain in the wrist or the elbow, some of the more distal neuropathies. Do you see that with a lot of TOS patients, that they get diagnosed first with a peripheral neuropathy before you see them?
I do. And I don't know, I won't put words in your mouth. I'm assuming you probably see that yourself, but yeah, the answer is yes. And then people go, well, wait a minute, I thought I had X, Y, or Z. And the answer is, well, you may. It's not that that's wrong. It's just that it's not all. That's not all, And so I think that these things, in some cases, are mistaken for a peripheral nerve entrapment. In other cases, it's in addition to a peripheral nerve entrapment. And so, what's been your experience there? I would say a resounding yes.
Well, for our viewers, just in case some of them haven't heard this before, multiple crush that Dr. Williams described is where you might show up to your doctor with a classic carpal tunnel syndrome, but in fact, a compression or tension on the nerves up here make the rest of the nerves down your arm more sensitive. So you may have a normal space for the carpal tunnel, but the nerve is just too sensitive. So it looks for all the world like carpal tunnel syndrome. In my experience, yes, absolutely. I think we see a decent amount of cases who have even had surgery first, and then it just recurs more proximally in the next joint up, which should be that red flag, which you've obviously already covered.
Yeah. I agree. We see that a lot, and that can be a point of confusion for patients sometimes, because they, they can't understand, well, why was I diagnosed with this or treated for this if my diagnosis is TOS? But you're absolutely right. That double crush is real, and those kinds of things where you have some injury or irritation or dysfunction of nerves at multiple different locations. And of course, that will significantly increase the severity of the symptoms when you've got two or more locations where the nerve is being inflamed or compressed or irritated.
How do you feel about the whole, some docs will say TOS is disputed, this thing that started with Wilborn back in the 80s. How do you feel about disputed neurogenic TOS?
So, I think that it's something that, we have to deal with, because you're right. There's people who don't believe, kind of believe in these patients. In my opinion, the proof has always been in the pudding. We evaluate, identify, diagnose, and treat the symptoms, and these individuals do very well. And so I think that it's been a matter of trying to educate not only the patients, but trying to educate physicians and the medical community as well. I can remember back in the 90s going to an American Academy of Neurology conference, national conference, and there was a presentation on thoracic outlet syndrome. It was limited to individuals with that textbook, cervical rib and claw deformity and what have you. And I asked some questions about, well, what about this, that, and the other? And at that time, the answer was no, those things don't exist. And usually those are in patients who have some kind of psychological issue or functional issue or what have you. And I just rejected that out of hand because of what I'd seen, experienced in my practice. But I think, as I mentioned, in terms of the history of this diagnosis in some of the publications in sports neurology over the years, we see this evolution. And I think we'll continue to see it, and for good reason, in terms of people accepting and understanding the mechanisms and the anatomy, and not kind of having blinders on and continuing to use words like disputed and what have you.
Right. The word disputed by itself just says you can shut off your brain, don't even think about it. And we don't make progress by not thinking about it. Obviously, you're pushing the boundaries in a lot of directions, and you're dealing with very high-end, demanding patients. So maybe some of your patients, as they get better, will help raise the awareness bar.
I think so. And I think that, I think you're absolutely right, number one. And I think that there are scenarios where if people understand, oh, that can happen to and has happened to, this athlete, and they've been treated for it and done well with it, that certainly, has a significant positive effect. You're right.
All right. I'm hearing more and more in the media, people like Markel Fultz. I don't think I'm revealing any privacy. It was all over the place that he was diagnosed with TOS.
Right.
And look, his rhythm, it fits perfectly into what you said, Vernon. His rhythm was just way off. You watched him. He went from a beautiful stroke to just different parts moving. It was, I don't know how.
You're absolutely right. And, interestingly, one of the things we did with him is we showed him visuals of his shot in college. And we had him train on we had an iPad device, and an entity that I worked with was able to develop this program for him where he could watch himself, watch his motion, and then he had to kind of tap a button at his release point, what he predicted his release point to be. But what we wanted that visual imagery because we wanted him to start to mimic that both consciously and subconsciously as we kind of put things back together with respect to his movement and his fluidity and his motion or what have you. So you're absolutely right. You picked up on that, and that's 100% true. Right.
That's a great idea to help him get back. Yeah. These, we talk about people end up with peripheral symptoms that seem unrelated to TOS, which could be due to posture, right? You talked about patients rolling their shoulders forward and their neck is lordotic. Then they got to change their lumbar spine because their center of gravity has changed.
Hey, Scott, how many times have you been in a room with a patient and you're looking at them and you're talking to them, and they're looking at you like this, right? And you say, well, what do you think about your posture? And they immediately go, oh yeah, I mean, my posture is like, and so I at one point I put a mirror in some of my exam rooms, and I wouldn't say anything. I just say, hey, stand up and come over here for a second. And before I asked them, I had them look in the mirror, and they would be completely unaware of their posture and shoulder girdle positioning. So you make an excellent point. That awareness is critical, and when we can kind of train that, and shoulder girdle positioning and that kind of thing, can make a huge difference, right?
Now you talk about how few of your patients end up needing surgery, which is great. If a patient comes in with severe costoclavicular narrowing, for our viewers, the plexus compressed between the rib and the clavicle, what do you think are the best modalities to get that space to open up without surgery?
I think it's normally a combination of things. We talked about some of the physical therapy and working on shoulder girdle positioning and posture and what have you. I used to have a video that I would show patients that really explained to them how the different positions of their shoulder and arm, it's not just their arm moving independently. The scapula is moving, and the clavicle and the first, it's a complex movement. And so it would help reinforce to people what happened with their shoulder in different positions. It wasn't just their arm, it was that whole complex. So that's part of it. I mentioned a couple of times, I will frequently do scalene blocks to relax those scalene muscles. Those muscles attach to the first rib. So theoretically and ideally, if we can relax those muscles, we can drop that first rib down a little. That may create a little bit of room. We can do subclavius muscle injections to try to relax that muscle. And then as I mentioned earlier, sometimes there is a component out at the pectoralis minor. I'm just looking for ways to open spaces up non-surgically, just to create more room and take any potential pressure off that neurovascular bundle at these points where they're frequently compressed. And so to answer your question, non-surgically, those are the kinds of things I'm thinking about. And it may be a little different. And sometimes, quite frankly, it's a little trial and error. We say, let's try this first and see what the response has been. And if it's good, great. If not, then let's try, something else. But we're trying to create room in those spaces and relieve pressure in different ways. Yeah.
Great way to describe it. So you're combining these injections with the right physical therapy. And I want to point this out to our viewers. It's not just any physical therapy. You have people you work with closely, don't you, Vernon?
That's right. We've been lucky because we've had some good physical therapists who really understand the anatomy and understand the condition. So it is worthwhile for the viewers to ask, hey, if you're thinking about physical therapy, does that individual have experience with thoracic outlet syndrome? And what kind of things have they done before? And are they working with any physicians who are experienced with thoracic outlet syndrome? Because all PT isn't created equal. There are people who are excellent at one thing and are pretty good at other things. So you want the person that's excellent at treating TOS to work with you. Yeah.
To go back a point to the shoulder girdle, as a radiologist and having to focus on this anatomy, I would bring up again a point I made on other talks, which is that there are 17 muscles that attach or arise from the scapula, the shoulder blade on each side. And really the shoulder blade is floating. It's gliding over the chest wall. Its only bony attachment is the collarbone. Mm-hmm. So for our viewers, and something that Vernon understands completely, is there's an imbalance in these muscles in many patients. And although it's complex because of the number of muscles and the different directions, that trial and error approach you take, also your exam to understand what's happening to the shoulder blades, is very important. I know on our study, our MRI study, we measure the position of the scapula in every direction, between up and down, because I don't even know the value of it yet, but hopefully it contributes to those clinicians who understand that. So you had mentioned you reposition scapula. I don't know if you use tape or manual manipulation, but I was hoping you could explain a little bit about what you do in that regard.
Yeah, so what we'll often do, again, we'll work with the therapist. Often the therapist, as you know, will kind of tape that shoulder blade and try to improve shoulder girdle positioning with tape. often in patients who say, yeah, that works well, we will prescribe a scapular stabilization brace, which is a soft, material brace. It's not a hard brace or plastic or anything, but it's like a little vest. They zip the vest. It's got Velcro in the front, elastic that crisscrosses in the back. And when they attach that Velcro in the front, it kind of positions the shoulder, so it helps to position that shoulder in the socket, but also helps to position the scapula. One of the points that you made about the scapula, I think, is excellent, and in that it floats. So there is a proprioceptive component to using that scapular brace or posture shirt, where the way I frame it and the way I discuss it with patients is part of what we need to do is retrain your brain on where your shoulder is supposed to be. Okay. And so in some ways, I'm as interested in that proprioceptive benefit of using the scapular brace as I am in the brace kind of physically positioning the shoulder blade or scapula, because eventually we want them out of the brace and still exhibiting good posture.
So we're not just forcing the shoulders into position. For the viewers, proprioceptive means you know where your body is with your eyes closed. What Dr. Williams is saying is we want to remind your shoulders how to assume a normal posture so it gets wired into your brain back again. Is that a fair?
That's
fair
exactly right.
Herb, I don't know if we have questions from some of our viewers, because otherwise I'll just keep bugging Dr. Williams all night long. All right. So my little sister fell on her wrist playing soccer. Her TOS started after that. Could the wrist injury have resulted in the TOS? She swears that that's true. This is Janie in Salt Lake City.
Yeah. So Janie, I think I would potentially agree with your little sister. And I can tell you one way that may happen. This is something I see fairly frequently. An individual has a fall or some other injury to the upper extremity. And what happens? They stop using it. It's immobilized. It may be in a cast. It may be in a sling. It may be that it just hurts, so they use it less. But it doesn't take long for disuse to result in atrophy and weakening. And so if you stop using that extremity, it may change the position of the shoulder because of disuse, and then they get laxity, anterior or internal rotation, and that can increase the risk of pressure on these structures in the brachial plexus and thoracic inlet region. And so I have seen individuals who have an upper extremity injury that the injury didn't involve the brachial plexus, but as a result of the injury, they end up with disuse, weakening, alteration in the shoulder girdle, and then because of that, the downstream effect is TOS. So that can happen for sure.
Thank you, Janie. George in Portland, Maine says, it seems like TOS with athletes is more common than the general public understands. Would you say that that's true?
I would. And I touched on some of the common, popular sports, but I got to tell you, in our practice, we take care of universities, we take care of, elite athletes, yes, but also high school, collegiate athletes. So I can't tell you, I see volleyball athletes, I see crew and rowing athletes. I see a number of different sports where people will end up with these symptoms of thoracic outlet syndrome. It is more common than you would expect. And I can tell you that from experience. It's not just stingers in football, which again, that first textbook, that was the only mention of TOS or brachial plexus.
Right. And swimmers, you probably see it in swimmers, right?
Swimmers, absolutely. Absolutely. Water polo, you name the sport,
right.
People can develop those kinds of symptoms.
But I'm betting, Vernon, that because there's somebody like you who's recognizing it early, you're getting relatively good efficacy and quick turnaround and getting them past it.
We are. And one of the things that's gratifying, Scott, is because we are likely to recognize it, the trainers that we work with, they no longer send patients going, we don't know what's wrong with this patient. Often they'll send patients going, does this person have TOS? Because they start to recognize the patterns as well. So getting the word out, disseminating this kind of information to other people in the medical field, whether it's other physicians, other athletic trainers, radiologists, or what have you, but also among the general public, now I think it does, make sense, and it's helpful to have the general public aware of these kinds of symptoms and this as a potential diagnosis as well.
That's really a compliment to you and your effect on these people in your community. I think that's such a great thing to hear that the trainers now start to look for it.
That's right.
So kudos. Next question from Maria in the Bay Area. Can you say more about pitchers, underhand versus overhand, and the mechanics of the two styles with regards to TOS? This is a cool question. Great
question, Maria. I don't know if you're a pitcher or an athlete, but there's a lot of insight in that question. So I appreciate it. Yeah, I can tell you that when I've seen underhand pitchers, so college women's softball, that kind of thing, generating tons of force, I'm more worried about vascular abnormalities, and in particular, arterial abnormalities like clot formation and aneurysm and that kind of thing. When I see overhand pitchers, then I'm a little bit more worried about either enlargement of those scalene muscles or some kind of stretch injury or what have you. Now, that's not to say that one group, can't get the other kind of problem. It's just it just seems that I've seen more in my practice and in my career, and it may have to do with the kind of mechanics that are generated with underhand, especially high velocity, elite level underhand pitchers. So Scott, have you seen any pattern in that regard from your standpoint?
I've not seen someone come to me with a history of an underhand pitcher, an elite underhand athlete, and I'd love to study those more. Did you say you see more vascular injuries in those patients than neurogenic? Is that what I heard?
Correct. I have. And maybe it's just a manifestation of what I've seen. So I'm, more, I'm surveying and more vigilant for that. But sure. I am, my threshold for ordering vascular studies is much lower in that female athlete, high velocity underhand. Maybe it's accurate, but it may just be my personal experience because that's where I've seen more of the vascular kinds of injuries. Yeah.
Well, that's fascinating to me. I'll have to keep my eye out. Mm-hmm. Thanks for the question, by the way. Does Dr. Williams do telehealth appointments? Somebody loves what you do and they want to visit you by telehealth.
Yeah, we do. As I mentioned, I'm with the Cedars-Sinai, affiliated with Cedars-Sinai, the Curlin Jobe Orthopedic Clinic, and our Center for Sports Neurology and Pain Medicine, and we do telehealth visits, telehealth evaluations. Yes.
Awesome. Jacob, maybe you can reach out to us and we'll connect you with Dr. Williams, get his office information for you. Baxter in Chicago says, can you explain in more detail why the blocks and Botox that you mentioned work for some patients and not for others?
Yeah, so Baxter, that's a great question. I wish I could say definitively why, but I have some suspicions as to why people in certain situations are more likely to respond to those injections than others. Some of it may just be the severity of the abnormality, how early we get to it. Some of it may have to do with whether or not there are significant structural abnormalities like cervical ribs, like these fascial bands that may extend from an elongated transverse process. Those are probably a little more difficult to overcome with the injections than someone who has some, just like what we described earlier, enlargement of those scalene muscles or postural changes. So that may have to do with it as well. But I think that the duration of symptoms, ideally, if we can get to things sooner rather than later, they're more likely to respond to non-surgical intervention. The severity of symptoms, again, severe incapacitating pain may be more difficult to overcome than someone with moderate degree of pain. And then presence or absence of significant structural abnormalities. And by that, I mean things like an aneurysm or a clot or a cervical rib. Those may be a little bit more difficult to overcome as well. So again, usually when we do those injections, the injections are of the muscles and the goal is relaxing those muscles to create more space. And most of the time that's effective and helpful. not all the time. And those are some of the potential reasons why it may not be sufficient.
If I could throw in my 2 cents on top of that, Vernon, thank you. The first injections, I believe, were done with any regularity in Los Angeles under EMG guidance.
Mm-hmm.
And I remain skeptical about the reasoning for it, but clearly I've seen patients I've injected that have had a tremendous response. I don't know why. I've heard the explanation that it allows the first rib to drop, and I'm very skeptical of that because of my radiology training and the changes I've seen.
Mm-hmm.
I think much more likely, because this is a muscle that starts on the C-spine, goes to the first rib. I think it's much more likely that the mobile C-spine will relax, and that will help some of the tension on the plexus. But I don't know why these work. I was talking to Dean Donahue. He's a surgeon, does a ton of surgeries at MGH in Boston. Mm-hmm. He knows incredible detail about the chemodenervation, mm-hmm. why it works molecularly, but he doesn't know why it works either. I think it's a great tool. Obviously, you use it in conjunction with physical therapy, you use it in your holistic picture. Yeah. But I would just say right now, I'm skeptical about the mechanism. So
yeah.
I think
and keep in mind that there are mechanisms associated with Botox that are completely unrelated to muscle relaxation. So right. We've used Botox, for instance, in migraine, and the mechanism is not felt to be related to any muscle relaxation in migraine. There's some other scenarios in which Botox may have an effect on pain separate from its effect on muscle tension. Often when we do the intramuscular injections, we use local anesthetic, but sometimes we'll use local anesthetic with steroids. So there may be some systemic uptake of the steroid that has an effect on pain as well. So I think that there are a number of potential mechanisms. I think that the point that you made about the fact that it's a piece of intervention that I believe has to be used in conjunction with other things. And so, I don't believe that you can just do an injection and that's it and walk away and a person's TOS is going to be cured. I think that's not likely and doesn't make sense to me.
Thank you. That's a good explanation. Christoph says, hi, have you seen scapular dyskinesis causing TOS? If so, how could it cause neck symptoms?
So, that's an interesting question, Christoph. So I'm not sure. This might be a little bit of a chicken and egg question in my mind. I'm not sure if scapular dyskinesis causes TOS or we just see those things in combination with one another in some cases. But I know that it's a really difficult condition to treat in many patients. So in terms of how it can cause neck symptoms, I would imagine that if in the presence of scapular dyskinesis, there's probably going to be all manner of abnormalities in the contraction of certain muscles, including those that are involved in the cervical spine, relaxation of certain muscles, muscular tone, proprioception. So I think that these things may be commonly seen in conjunction with one another, but I'm not exactly sure if one causes the other. I've seen people who've had shoulder injuries and then as a result of that injury develop some scapular dyskinesis. Now it gets really interesting, I think, when you start to consider this whole concept of the nervous system and the nervous system's kind of primary job of surveying for threats, and then the response that you get, which in some ways has to do with muscle tension and tone and what have you, and the fact that you can get aberrant signals, or you can get the nervous system responding to information that it perceives as threat, even though threat isn't present, and how that can have an effect on muscle tension, tone, pain, and the like. Including proprioception and what have you. So, but to answer your question, I'm not sure if one causes the other, but we certainly see them in conjunction and in combination. Scott, what are your thoughts on that?
I think you did a very good job, Vernon, of describing it. There's a lot we don't know about this. there's plenty of potential for scapular dyskinesis because of the complexity of this motion. The Peck Minor syndrome, which I was going to ask you about separately, is classically described as compression of the neurovascular bundle beneath the Peck Minor muscle. But the imaging literature that I know, and from I've done 3,000 cases, I don't think that's the case. I think it's another source of scapular dyskinesis. The first Peck Minor tenotomy was done by a guy named Jerry Lord in 1950, and it worked. And just like the Botox or the scalene injections with lidocaine, I know it works, but I don't think it's been explained so well. Yeah. So I think that the what you're talking about, how you handle these patients, your more holistic approach, everything in the whole chain from the bottom up, is probably the best way to handle that. Again, just like injections, I think if you just fix the dyskinesis without anything else, I'm going to guess you don't have as good a success rate. So I don't have an answer for the chicken and the egg, but I think this and Peck Minor syndrome are tied together, and I certainly think it's a big part of TOS for many patients.
Right.
Another question from the same Christoph. Does a single trauma like football players face cause a worse prognosis than repetitive injury? This is a good question.
Yeah, I think that's an excellent question. I don't think so. I'm a little bit more concerned about people who have kind of repetitive injuries, micro traumas, kind of insidious development or what have you. The single trauma, like what was described in football and these classically described stingers, the overwhelming majority of the time, they are asymptomatic in between episodes, even if they have multiple episodes. And the overwhelming majority of the time, the episodes are short-lived, they're self-limited, and we're doing things to try to prevent recurrence. It's very uncommon for them to have prolonged symptoms. Even when they have prolonged symptoms, again, they will often and typically recover and improve. These individuals with the repetitive injury, in my experience, they end up with symptoms all the time. It may start with certain activities and in certain positions, but then they come to a point where they seem to have symptoms kind of continuously and have a lot of difficulty, overcoming them. And it normally, in my opinion, takes a lot longer, a lot more work. Not that it can't be done, but it's a more significant and prolonged process, usually.
That's a great point. I think some of the best descriptions I've heard have been people who have symptoms at work because they have an occupational cause, and then they go home at night and they feel better. But over time, the symptoms last overnight. And then over time, the symptoms last over the weekend. And my uneducated guess is that it's initially due to the direct impact, whatever repetitive stress. But then once the nerves get damaged, they start sending out abnormal signals. The membranes get unstable. And so it's another one where we want to pay more attention, I guess, when they start getting persistent symptoms beyond the inciting factor. My 2 cents.
I agree. Yeah.
Herb, if we don't have any other questions, I really want to thank Dr. Williams for, that was a great talk. I love listening to all of this. I think it's a wonderful approach to TOS. I hope that hopefully we'll get to work together on some patients because I'll probably learn a lot from them. And I want to thank you for your time.
Well, the feeling is mutual. I'm really looking forward to collaborating with you. I enjoyed it. I thought the questions were great. So congratulations to the audience that you have. They're very educated, and I really had a great time. So thanks for having me. I really appreciate it.
Thank you. Thank you. Again, you're at Cedars-Sinai at the Sports Neurology and Pain Management. I hope I'm getting close. But if we have patients contact us, I will definitely put them through to your staff.
Okay.
I want to remind our viewers that we have another talk coming up on toseducation.com, as you see on the bottom here, Tuesday, February 15th. And I'm going to be actually talking on that one. All our viewers come to my website, tosmri.com. You can contact us through the last menu on the right, and we're happy to answer questions that come up from Dr. Williams' talk or to connect you with people that we work with. And again, thank you, Vernon. I learned a lot. I never fail to be impressed by somebody who's so deeply involved in it and sees such a nice big picture. I really love it.
I appreciate it. Thank you.
All right. Look forward to talking to you soon. Thank you.
Same here.